So with this said, it brings me to the practices in regard to the treatment of advanced HCC. And if anything, I jokingly say that all of us had an easy job. We had only to remember one drug, sorafenib. So tell us, like, we lived with one drug for almost 10 years, and but tell us where it all started. What was the sorafenib story altogether to begin with?
So sorafenib is the first ever approved systemic therapy for patients with advanced stage liver cancer, and it is a oral therapy, and it is approved because of its prolongation of overall survival, and the response rate actually is not that great. It can slow down the progression of the tumor and result in a survival benefit.
Which I remember, this was 2007, and we had all this great story. And understandably, even though we say that there's no response, but no doubt that the drug works because it works in a different way. It's a tyrosine kinase inhibitor, and not necessarily that it requires that the tumor will shrink per se. And nonetheless, patients will come and ask you that question and say, like, what do you mean it's not going to shrink tumor? Especially, remember, as you just mentioned a second ago, patients might have had a local therapy and are used to the interventional radiologist saying, oh, great, we shrank it, it's smaller, and now out of any tell them, we're going to give you a drug, you're going to have longer, but it's not going to shrink the tumor. So how do you explain that?
It's certainly challenging because both physicians or healthcare professionals in general and patients like to see shrinkage of tumors. However, as you introduced, this is a cytostatic drug, and it is well known that it changes the behavior of the tumor. The exact mechanism of action is not necessarily clear, but as you said, by slowing down the progression, prolongs survival. I do explain to patients that unfortunately, when they get to the treatment with sorafenib, they are in a stage where they're not curable anymore. So the goal of the therapy is to balance prolongation of life and preservation of quality. And that's the intent of the therapy. And I think that's the best way to help patients understand that, is what is the goal of the treatment? And the goal is life prolongation while preserving quality as much as possible. The other relevance here in the discussion is that we do not know that response rate by itself is a great predictor of outcome in hepatocellular carcinoma all the time. It's not always a predictive marker. Let's say in a phase 2 study, we may have a good response rate. That doesn't always translate to overall survival in a phase 3 study. It's a technical point, but it tells us that in this disease, response is not everything and may not be always the most important marker.
That's great. And Catherine, from your standpoint, because remember, we have probably the most ample experience with regard to sorafenib, but back to the point that you brought up about the liver functionality component per se, what are your concerns? Do you think we have no clue what we're doing, or like what are we supposed to do? But like this is an important aspect. Like how do you gauge between the liver functionality and sorafenib?
It is because these patients have two diseases. They have liver cancer, they have end-stage liver disease by definition with cirrhosis. It is really important to have a hepatologist and an oncologist working together on these patients and really communicating well. Even ideally, sometimes having the same clinic together where the patient can see both physicians at the same time. We do have to watch carefully for decompensation of their liver disease, development of ascites, encephalopathy, jaundice, coagulopathy, all of these issues that can happen because those are going to affect patients' survival as well as the tolerability of any systemic therapy either now or in the future.
Fair. And if anything, I recall that in the old days, a patient's on sorafenib stopped working. We don't know what to do other than probably a clinical trial. But as we just introduced the program, there is a lot of new data, and among which a drug called regorafenib. So, Ruth, tell us, what's regorafenib and what do you know about it?
So regorafenib is very much like sorafenib. It targets many similar genes, and it's also oral agent. But amazingly, when it's tested in the randomized phase 3 trial in patients who have progressed on sorafenib, or who have additional benefits, survival benefit from this drug. So now the randomized phase 3 study, the data has supported its approval by FDA in April of 2017 that provide additional second-line options for those patients who have progressed on sorafenib.
Yeah, no, I totally agree. If anything, regorafenib is probably a cousin, but I like to call it a distant cousin of sorafenib because admittedly, there are certain aspects of it, including TIE2, including IGF, including the other markers and the IC50 of those that are expressed that differs from sorafenib. And more importantly, as you said correctly, is that patients who progressed on sorafenib, they really actually did progress on sorafenib, they get the regorafenib and they get another improvement survival for another 10 months. Actually, even I was happily surprised to see that actually the joint survival of sorafenib exposure followed by regorafenib exposure is up to 24 months, which is incredible.
Which is amazing.
Incredible.